Welcome to the Teaching Value in Healthcare Learning Network. Join us to hear leaders in the field share practical and tangible advice about how to develop engaging curriculum and health system innovations to train a new generation of healthcare providers from diverse specialties and professions skilled to deliver high-value care. With national concerns about rising healthcare costs, as well as overuse, underuse, and misuse of medical care, Cost of Care and the ABIM Foundation created the Learning Network as a space to share ideas, educational materials, and strategies in an open forum. So our Teaching Value Network, its goal is to really teach us how to get started, begin implementation, and sustain feasible innovations in teaching value at your institutions. The Teaching Value and Healthcare Learning Network has three components. First, our monthly webinars, which are 30-minute sessions to hear on-the-ground and national leaders share successful innovations with a focus on how to adopt them to your institutions. Sessions are held on the third Thursday of each month. We also have affinity groups that is an online forum to facilitate getting advice on how to launch new innovations, and we hope to help each other troubleshoot challenges that might arise. The third component is Tools for Educators and Health System Leaders. It's a space to store materials for dissemination of curriculum and other innovations to community members across the country and in Canada. And we have a number of tools already available right now, and we'll continue to add more over time. So I am Reshma Gupta. I'm the director of the Learning Network and will be moderating today's webinar. Today we will share an innovation in teaching value and discuss in-depth practical components of implementation, including how to obtain buy-in, the resources that are needed, and advice about feasibility and sustainability. We are honored to have Dr. Swaroop, who is an associate professor and the program director of the Internal Medicine Residency Program at the University of California, Irvine. She has developed a novel longitudinal business of medicine curriculum in the Internal Medicine Residency Program at UC Irvine among trainees. The curriculum introduces critical thinking to cost awareness and cost consciousness and covers medical economics, the Affordable Care Act, and American history related to this, and incorporates high-yield articles, ACP high-value care modules, including board exam review questions. Residents are then expected to create a cost-conscious project that's relevant to the goals in inpatient medicine at their institution. She has published and presented her prior curriculum in the academic internal medicine and at program directors' annual conferences. So Dr. Swaroop, I will let you take it away to describe your curriculum and share what you're doing over there in Irvine.
So thank you for having us. We really started this curriculum in 2011. During that time, what was happening is the Affordable Care Act was being rolled out. The ACP had just come out with their new modules, their learning curriculum in high-value care that they were hoping residency programs would roll out in their individual institutions. And we thought it was a great opportunity to try to align a business of medicine curriculum along with the idea of promoting high-value care, thinking that the earlier we start educating our residents on the concept, the more likely they are to actually integrate that thinking into their practice even after they leave residency or fellowship and beyond. And so we created a longitudinal curriculum that really started in the intern year. Every July we have a month-long series of conferences that are called our fundamentals. So instead of a traditional new conference, we really gear up a series of topics towards what does an intern need to know. And we thought starting that early on would be really important to try to build a longitudinal curriculum. So early in July, we have a new conference that's dedicated to just an introduction into the concept of high-value care using the 5-step framework that the ACP put forward, and really introducing the idea to the interns and letting them know and empowering them to say, you can critically think about what you're ordering and what you're doing. You just don't have to listen to your senior resident. You're attending. We want you to ask the question why and how is this appropriate for this patient in this situation. So building on that, during the second year of residency, and we actually have these modules distributed all throughout Noon Conference. So we start with the fundamentals in July, but we do the rest of the modules during Noon Conference throughout the year, so they get exposure to the different ideas. In their second year of residency, we have a fun, we've created a fun 3-week rotation called our doctoring skills rotation, and a big component of it is really our business of medicine curriculum. So at this point, they've been introduced to the concept of high-value care. They've been practicing it, hopefully, on the inpatient and outpatient setting. But now we get a little bit more intense, and they actually have a dedicated seminar in the business of medicine. They have a binder of articles that are high yield that they read. We actually have them write an essay, which is a lot of fun because they haven't written an essay since their personal statement. So we have different prompts we have them look at to get them thinking about the business aspect of medicine. And then my favorite part is really having them develop what we call cost-conscious projects. So stemming from an article that was published in the Annals of Internal Medicine in 2012 that was looking at appropriate use to foster high-value, cost-conscious care, we have them look at that article and at the table to get them thinking about things they order on a regular basis, either a diagnostic or therapeutic, that when they really think about it, may not change the management that they're doing for those patients. So we use that article as kind of a sounding board for ideas, and we ask them to pick a diagnostic or a therapeutic that they want to review. And we have them review a minimum of 10 patient charts. A lot of them have gone up to 40 or 50 patient charts because they get really excited as they're getting this data. And look at what the evidence is. You know, what is the current guidelines by the different societies? What is the actual EBM behind this management or therapeutic? And then they do a chart review. And we're fortunate we have an EMR at all 3 of our training sites, so it's pretty easy to mine the data. They look at how we're doing, how we're practicing for a certain time period. They gather that data, they put it together in a PowerPoint, and they analyze and say, you know, are we really following guidelines? Are we doing what's appropriate? Are we providing high-value care or not? And then we ask them to do kind of a cost analysis, what the cost is to the medical center, what the charges to the patient. We also ask them to look at possible adverse effects that might be happening by ordering contrast studies or by doing extra phlebotomy that's unnecessary, pain to the patient, discomfort, or future testing downstream. It's not meant to be statistically significant. It's just meant to get them thinking about our ordering habits, our practicing, and how they really have control over that, being in the front lines of medicine in their residency program. And we actually take this one step further, and so we have them, you know, have a conclusion slide about possible interventions. So based on their findings, what do you want to do? What do you think we should do to try to change our practice habits? And then we ask future residents, as they become second years, to do a follow-up study, see if based on an intervention, whether education, development of mini lectures, faculty development, whatever it is that needs to take place, have we made a difference? Have we had an impact on that practice? We also have them present at noon conference in their 3rd year so that, you know, they've been exposed to the teaching in the 1st year, they've done these projects in the 2nd year, in the 3rd year they deliver these talks to all the residents during noon conference, and they can disseminate their ideas and their findings to the house staff and to the faculty that are at those conferences. So it's been a really nice longitudinal development that takes them through all 3 years of residency. And staying in touch with residents that have left, you know, UCI because they've gone through this whole curriculum, we know that they're still able to apply this in their future settings. And a lot of times they're astonished by, by some of the practicing habits in the community. And so it really creates sustainability from that end.
I had couple questions just to clarify too. In that 1st year, who do you actually have doing the teaching for the 1st year residents? Are you pulling in folks with different backgrounds for that?
A couple different. So myself, since I was part of developing the curriculum, I actually deliver most of the ACP modules, and I actually have taken them and edited it and really tried to tailor it for our institution, taking our numbers and cases that we have had here and really making it more individualized and personal for the residents here at UCI. So I really deliver most of the modules during noon conference. We also have what our former program director and vice chair of education at that time, who helped develop this curriculum, also does a business of medicine seminar and some of the lectures. And then the other thing I forgot to mention was what we're trying to do is also during morning report, when we have residents presenting cases, instead of only focusing on the diagnostic thought process, we actually have added a section of our morning report that's called workup and management. So we ask the residents, okay, based on your key factors and your differential, what high-value care workup are you going to start in this patient, and why? You know, what is that based on, and what's your thought process? How is this going to change your management? And that's really both myself, our hospitalist, our chief residents run the morning report sessions. So it's been a nice way of getting the chief residents involved and also the hospitalist faculty involved in the concept of high-value care. So it's a combination of a few core faculty and chief residents that are doing most of the teaching.
One thing I think would be really interesting is to hear more about how the residents and even medical students that are on the wards and seeing some of this reacted to it, especially in that first year that you were rolling it out.
Absolutely. So, it was a really interesting response. The residents were really excited. The first time I did the introduction to high value care lecture, I had 3 or 4 medical students actually come up to me afterwards and say, can we get this in medical school? Because we feel like this would be really helpful even earlier on, even before residency. Because many of them had not even thought of it. They just felt like, we have these labs, we have these diagnostics, we have access to CAT scans and MRI, why wouldn't we? Why wouldn't we order all of these things? The more the better. And again, I think the business aspect, the cost aspect have been lacking in terms of residency curriculum. I think a lot of us as physicians don't want to think about it because we just want to be able to have freedom in what we're ordering, but we don't really realize the impact it has on patients and the charge to them and their bills ultimately at the end of the day. So part of my introductory lecture, I actually show a patient bill, an actual patient bill that one of our residents whose grandfather was hospitalized got, and I think that's really eye-opening for them. The reaction from the residents and students was a little bit different than the faculty, as you may imagine. So the residents and students are coming in really fresh and open-minded and really accepting of what I'm talking about, the concept of high-value care. I think the faculty, on the other hand, depending on the different experience level and different areas of resistance. So some newer faculty who have just recently trained are a little bit more open to the idea. I think we've met a little bit of resistance with a few of the older faculty who, we have one hospitalist who loves to say, why not order a CMP in everybody? Our CMP includes albumin and LFTs, and it costs the same. It's the same machine, it's the same blood draw, so why wouldn't you order a CMP? And so I love showing this bill because the patient was charged $1,000 for a CMP. I'm like, yeah, it may not cost a medical center that much, but certainly the charge to the patient is very different. And so it's been interesting to see the dynamic between the residents who are like, well, wait, maybe we only need a BMP, or maybe we don't even need that morning lab, versus, obviously getting the faculty on board with the concept.
That brings me to another question, too, which is really getting a sense of what the culture was at your institution before you started. And now that this curriculum is out there, have you noticed any changes in the culture in terms of, high-value thinking?
Absolutely. So, prior to rolling out this curriculum, the terminology wasn't even there. The idea of high-value care wasn't really part of our teaching. It wasn't really talked about in our management. There were a few faculty who definitely promoted the idea, but it wasn't ingrained in our culture at all. And I think really now we're in our 5th year of having this curriculum in our residency program, and I've also done a lot of faculty development. I've also, since that time, talked to nurses and ancillary staff and other departments and divisions, and now we're starting to see really a cultural change where not just internal medicine, but even emergency medicine, even surgery, transfusion medicine, we're all teaming up and really trying to promote that idea across the residency programs, across the different departments. And now when my residents talk about it or say, well, do we really need to order that morning lab? Or not even talk to the attending and just not order it, that's not questioned anymore, because as long as they have a justification or a rationale for why they did or didn't do something, it's really a lot more expected than just having this idea of you should order daily labs every morning. You should have that daily chest x-ray in the ICU. There's definitely been a shift from where we were in the beginning.
How did you get started? How did you gain buy-in for this kind of longitudinal curriculum, and what were the resources?
So the buy-in was certainly important. I was fortunate that at the time we had a lot of support from our leadership. Our department chair was very supportive. The hospitals program was supportive and really allowed us to embrace the idea of high-value care and introduce it into the residency curriculum. There were, the first part, the buy-in by the residents wasn't so hard, because once you start introducing the idea, they're already open to it. I think some of the barriers that we faced, I anticipated, obviously the faculty, and so after rolling it out to the residents, we actually also started rolling it out to the faculty. I delivered the same talk I gave to the residents on high-value care. I actually delivered it to our hospitals faculty, because I wanted to make sure they knew what we were doing and were on the same page, because on a day-to-day basis, they were overseeing the residents on the inpatient wards and needed to know that they were going to be asked these questions by the residents. They may not expect daily labs every day. We were going to be trying to minimize unnecessary ordering. The barrier I did anticipate, or at least didn't think about ahead of time, was actually the nursing side. It did occur to me that I also needed to roll out this curriculum to nursing. So as an example, we tell our residents, you don't have to order morning labs the next day. So they don't. What would happen, though, is the nurses would be checking the chart, expecting there to be an order for 8 a.m. labs, and if they didn't see it, they would page our night float resident. The night float resident didn't know, and so thinking that the daytime resident had missed it, would order it. So inadvertently, we were getting labs that we had actually intentionally not wanted. And now we're realizing that probably needs to be part of sign out is no AM labs needed, or only this needed. So letting the nurses know and the ancillary staff know what we were doing. And then obviously the buy-in of specialists. So one of our cost-conscious projects as an example was daily chest x-ray ordering in the ICU, and more recently daily EKG ordering in the CCU, as I found out we're doing apparently. So really getting buy-in about what our results are, what the evidence is behind these, and then going to our specialist faculty and saying, hey, is this something we really need to be doing? Is this really providing high-value care to our patients? The nice thing about this curriculum and what we've done is it's not resource-intensive, it's really resident-driven. You just need a few faculty that can deliver the modules or chief residents. It's easily integrated into a morning report and noon conference format. The ACP modules are already there and online that can be individualized to any institution. And it really, creating the cost-conscious projects are done during the resident's own time. Doesn't take a lot of, with most institutions having EMRs, it doesn't take a huge amount of effort, but the results can be pretty amazing. We've been able to drop our unnecessary echo ordering by a significant amount. We've dropped our unnecessary use of PPIs on the wards for GI prophylaxis. We've reduced our daily chest x-ray ordering. We made a huge drop in our unnecessary blood transfusion rates, and all within just a short time period and not a lot of resources that were needed for it.
We often talk about the silos between the health system folks and the education folks and making sure that they're getting the same message. So that's really great to share. One question I had, considering you mentioned a lot of these rates really improving in a short period of time, is if you could share one or two specific projects that residents chose to do during their second year and then were able to share the year after as their third year.
Yeah, so there's one project that always sticks out in my mind because it was so profound. One of our residents, he did a study during 2012 and presented it in 2013, and he specifically looked at transfusion ordering practices. And I'll show you a few slides from his project. And as I mentioned, these are short presentations. They're not meant to be statistically significant, but we actually did a follow-up study, and it was really amazing in terms of what we found. So he looked at how we were ordering blood transfusion in 2012, and he found that the average admission hemoglobin was 8.5. It was about 4 days between the admission hemoglobin and then needing a transfusion. And at the time, most patients that were being transfused already were at a hemoglobin above 7, which is nowadays our threshold. But everybody was getting transfused 2 units at a time, and their post-transfusion hemoglobins were almost 10, 9.5 to 10, which we know based on guidelines and evidence is really not necessary. And so what he was saying was, why are we ordering 2 units at a time? Why are we transfusing at hemoglobins that are greater than 7 or 8, which is the general threshold? And he also did an analysis of what types of patients were being transfused, and we found that it wasn't just our GI bleeds, but a lot of patients that had end-stage renal disease or were dialysis patients were a huge part of this population. And, again, transfusing 2 units means their hemoglobin goes up by 2 points, and that's what we were finding here. So in his study, he did a pilot study of about 40 patients, but based on his results, he actually went back and did a year's worth of data, and he looked at over 2,000 patient charts. There were over 10,000 units of red cells that were transfused during that time at our institution. The average number of units transfused per order were 2, not the 1 unit at a time that we know is evidence-based. And he did a cost analysis where the total direct cost was $3.8 million. And as a result of the study, we went to our blood bank, we went to our transfusion medicine specialist, and we said, what can we do to try to improve this? Because over $3 million worth of transfusions, transfusing 2 units at a time, how is that needed? And what we were able to do was, I just got the data actually just a few months ago from our blood bank, we dramatically reduced the unnecessary transfusion ordering. We're now just over 1 unit at a time. And they're actually using internal medicine as the sounding board for everybody at the institution, saying, look what medicine did. Can surgery and OB-GYN and everybody else also follow along with this? So really looking at what's the evidence, what are the guidelines, how are we doing, and what can we do in terms of implementation and strategy. And so within a 2-year time period, we were able to really significantly reduce unnecessary transfusion ordering. We also have about 50 projects on our website now that we have links to the projects for anybody to be able to take a look at. So we have our original studies and then our follow-up studies, things like how we're doing with VTE prophylaxis, echo ordering, troponin ordering, serial troponins, daily x-ray ordering, as I mentioned, and quite a lot of variety. They've expanded to telemetry use. You know, are we appropriately putting patients on telemetry? Are we ordering CT angios appropriately in patients with suspected PE? The list goes on, and it's really been fun to see how creative the residents have gotten with the different diagnostics, therapeutics, and just utilization of healthcare in general.
Ask you a couple more details about, you know, when the residents are off doing these projects, what kind of support or resources are provided for them to kind of talk to them about how to do the chart reviews, or, you know, how to kind of get some of that cost analysis information at your institution?
Absolutely. So myself and one of our other hospitalists really help oversee their creation of projects, help mentor them through the projects, and then also we have a point person this was one of the barriers we had during the first year, how do we even get the cost of these? So we fortunately have a point person here at UCI that has been able to provide that cost for us, and then now after having done the studies for a few times, we know the average cost to the medical center of many of these different procedures and tests. On top of that, there's so much online now in terms of the average charge to the patient, not just having our patients' bills here at UCI, but just the national average of what patients are charged for different studies. So a lot of the information is now publicly available, but we have created a cohort of faculty as well as staff here that are able to provide that information to the residents depending on what they're choosing for their cost-conscious project.
Perfect. And I also wanted to ask you, you know, if you're talking to somebody who's just embarking on creating a curriculum like this at their institution, you know, what do you think are the top 3 things that led your curriculum to be a success?
Yeah, I think number 1, you definitely need a core group of faculty. Just 1 or 2 is needed, but you need at least that, you know, 1 or 2 faculty to be able to drive the curriculum, to oversee it, to ensure that it's getting scheduled, or a chief resident, to deliver the modules during noon conference, and then to really be able to help guide the residents in doing their cost-conscious projects and review it with them at the end. Those same people can also do the faculty development, since they're doing a lot of the resident development as well. I think the second thing is you need leadership buy-in and support. You know, because if the residents are coming up with these ideas, showing meaningful results, and then there isn't buy-in to try to implement change and have outcomes produced, that's really hard for residents to see and even faculty. So you need that leadership buy-in to actually show implementation. And then, you know, a multidisciplinary aspect. And I think that's probably, if you have the first 2, the third will come after that. But realizing that this isn't just enough to have the residents and faculty on board, you do need other specialists and departments and ancillary staff at some point as you're rolling out the curriculum to be on board with this as well. But certainly the nice piece of this is that I've never encountered any resident resistance, and it is a resident-driven curriculum. So as long as you have your chief residents and your 1 or 2 faculty to be able to oversee it, that's generally enough to get this going and even sustained.
And what I really love that you shared was that because you've been working on this for almost 5 years, as you said, that you learn each year from things that you maybe didn't have the first year, and then you're able to get the cost data, you know, starting in the second year that, you know, might seem daunting to folks that are just starting this, to say, my gosh, there's so many aspects to this and so many groups to target, but it really seems like a work in progress, and kind of groups got added in, meaning the faculty as well as the nursing and the other team over time.
I was just going to say it was just me, and then I remember the first 2 residents I worked with, they didn't even have full
Go
PowerPoint.
ahead.
They just looked at a urinalysis and they called the lab and said, how much does it charge to do a urinalysis? And it was a very, it wasn't sophisticated, it was small, but it got us started.
No, that's great. That's really great. I think that's the thing, is that having those faculty champions, like you said, and really easy examples, that's when you start seeing that culture change, and then things start rolling and you get more resources as things start working. You mentioned one barrier that you faced, which was, obtaining the cost information in the first year, and that eventually someone was there to help with that, and that resource was provided. But are there other barriers or kind of things that you wish you would have known on embarking on this that you can kind of share with us?
Yeah, I think the main ones were realizing that I should have done faculty development at the same time I was rolling it out to the residents, not later. I think it would have really helped if I had rolled both out together simultaneously, because then there would have been a delay from the residents coming back on the inpatient wards or in clinic and saying, hey, what about this idea of high-value care and really cost containment? And in the beginning, the faculty weren't aware we were doing that. So really doing it simultaneously, I think, is helpful. Or even telling the faculty ahead of time, this is something we're going to be doing and implementing with the next academic year, and getting them on board ahead of time, I think would be really helpful. Also, thinking ahead of who would that person be that could provide the cost analysis or that data, so that when the residents are starting to develop their projects, it's not an afterthought of, oh, now I need to scramble and go find this information, but who is that person, or is it the lab, or is it pharmacy that can provide that information to the residents, so that contact information is already there. And then as this is being rolled out, I think it is important that there's a mechanism to meet with nursing, meet with respiratory therapists, or meet with some of the specialty faculty and say, you're going to notice that we're not ordering daily labs, or you're going to notice that we're not ordering daily chest x-rays. We want you to be aware this is why we're doing it. The last thing I didn't really realize was a barrier until later, and I would encourage everyone to check, is that our electronic medical system was kind of a barrier in a way. So there's actually an order, as an example, where you can, on admission, click off daily labs, and it repeats every single day without the resident having to think of it. And so for me, that was really eye-opening. I thought, I just need to teach this curriculum, get them thinking, have them do these projects. But if it's that easy to order daily labs, and you're automatically going to just click off, repeat every single morning without having to think about it, those are some of the barriers that at a systems level need to be addressed also.
Perfect. I think it's the same kind of theme as including all of the members that are affecting the residents, including the faculty, as well as the team and the system and EMR that they're working in, is going to create the most change. Well, I want to thank you so much for joining us today, and for all of you for joining in this discussion. Remember to check out the Tools for Educators and System Leaders link off of the main page of our website on the left side, where you'll be able to see some of Dr. Swaroop's description. And we want to invite you all to join us again next month on Thursday, May 19th, in which we'll be able to share an innovation from members of the American College of Radiology. Thank you so much.
Thank you.